Hello, my name is Siri and I am a PharmD student at Drake University. Today I will be briefly discussing torsemide. First, I will talk about the mechanism of action of the loop diuretics, which includes furosemide, bumetanide, torsemide, and ethacrynic acid. Here we have a drawing of the nephron in the kidney, and the loop diuretics exert their effects in the ascending loop of Henle, which is shown by the arrow. Zooming in to take a closer look, these diuretics block the action of the sodium-potassium 2-chloride cotransporter, which is denoted by the purple oval in the drawing, and this increases the amount of sodium in the urine, and water follows sodium, so more water will be excreted into the urine. By blocking this cotransporter, there will be an increase in all of the listed ions in this table in the urine, and the loop diuretics will also cause decreased uric acid excretion. Now I'm going to jump into the adverse drug reactions that may occur in patients taking torsemide, as they are closely linked to the mechanism of action that we just discussed. Loop diuretics, including torsemide, may lead to AKI due to fluid loss, but torsemide may be associated with less risk of AKI when compared to furosemide. Given the mechanism of action of torsemide, volume depletion is going to occur as water follows sodium out into the urine. Due to the excess sodium and potassium ions, the overall electrical charge of the urine has changed slightly. In turn, less magnesium and calcium is passively reabsorbed into the bloodstream, and this combines to cause both fluid and electrolyte loss in the urine. Loop diuretics can compete with uric acid for excretion into the urine, thus increasing uric acid levels in the blood. There is also evidence that loop diuretics may inhibit other uric acid transporters, which would also lead to hyperuricemia. Immune-mediated hypersensitivity reactions have also been seen. This is due to the sulfa group that's denoted by the green circle. The onset of this reaction is varied, but typically it occurs within days or up to 8 weeks after drug exposure. And it may occur more rapidly with re-exposure to the drug, usually within 1 to 4 days of that re-exposure. And then ototoxicity occurs because the same sodium potassium 2-chloride cotransporter exists in the inner ear, and the drug can then impact the ionic composition of the fluids in our ear, which leads to tinnitus and hearing loss. And these are typically reversible once the drug is stopped. Given the adverse drug reactions that can happen when a patient is taking torsemide, it's important to keep these monitoring parameters in mind. In general, there are some nuances that make torsemide a bit different than other loop diuretics. When it comes to pharmacokinetics, the onset of action is about 1 hour, and the duration is 8 to 12 hours. This is a similar onset to furosemide, but the furosemide duration of action is only 6 hours. Other potential advantages of torsemide over furosemide are its long half-life, high oral bioavailability, and less loss of potassium and calcium ions in the urine. Another thing to note is that torsemide is approved for the treatment of hypertension, but furosemide is not. The mechanism of action of low-dose torsemide to reduce blood pressure is unknown, but the low doses of torsemide used in the treatment of hypertension appear to be non-diuretic. Torsemide has been reported to be an inhibitor of aldosterone, which may account for some of the inhibition of the compensatory rebound that is mediated through the renin-angiotensin system, and thus causes decreases in blood pressure. Torsemide has increasingly become an area of interest when it comes to its research potential. This figure is from a meta-analysis published in the Journal of Cardiac Failure that included all published randomized controlled trials and observational studies that compared torsemide and furosemide use in chronic heart failure patients through February of 2019. It was found that torsemide use improved functional status and reduced rehospitalization due to heart failure compared with furosemide in chronic heart failure patients. Torsemide was also associated with reduced cardiac mortality, but that effect does require further study. Transform HF is an ongoing phase 3 trial that is currently enrolling patients. Longtime clinical experience has contributed to dominant use of furosemide for loop diuretic therapy. Small clinical studies suggest potential advantages of torsemide over furosemide, however. At this point, there is insufficient evidence to conclude that torsemide should be routinely recommended over furosemide. Given this gap in knowledge and the important role that loop diuretics play in heart failure care, the Transform HF trial was designed to definitively compare the effect of a treatment strategy of torsemide versus furosemide on long-term mortality, hospitalization, and patient-reported outcomes among patients with heart failure. It will be interesting to see where this trial and others lead, and if definitive clinical conclusions will be drawn from the data going forward, especially in regards to diuretic recommendations found in treatment guidelines. Here are the references used to create this presentation. Thanks for tuning in, and I hope this helped you to learn more about torsemide.